We're going to talk about endometriosis today. Endometriosis affects almost 30% of women who are consulting us in our clinics. In normal population, maybe endometriosis affects 10% of the population. We have a saying, not all women with endometriosis have infertility, but many women who have infertility also have endometriosis. This is how important endometriosis is in our practice. Let us understand today what endometriosis is, how does it affect fertility, and how can we manage fertility associated with endometriosis in these modern times. See, what happens in a normal menstrual cycle is every month the follicles develop in either of the ovaries. So sometimes in the left ovary and sometimes in the right ovary there is one egg that matures. While the egg is maturing, it starts releasing a hormone called estradiol. This hormone is the most important hormone in the first half of the menstrual cycle. What it does is it builds up the endometrial lining inside the womb for the lady. Slowly, as the egg matures, the lining also develops and becomes ready to accept the embryo. On the 14th or the 15th day of the cycle, the egg gets released from the follicle inside the ovary and is picked up by the fallopian tube. Inside the tube, it stays alive for the next 12 to 24 hours. During this 12 to 24 hours, if there is a physical contact with your partner and there is no other problem, the sperms travel all the way from the womb into the tube and fertilize the egg to form an embryo. Once a pregnancy happens, this embryo trickles down the tube into the womb and settles in the womb. If the embryo settles in the womb, then you end up with a pregnancy, and that's how it all happens. But in case there was no sexual contact or the egg did not get picked up by the tube this month, then in most circumstances there is no pregnancy. And if there is no pregnancy, then the endometrium lining that had built up so nicely over the last 4 weeks now sheds off and comes out as menstrual flow. So essentially, menstruation is breaking up of the endometrium lining and coming out of the womb. What we can see outside is the menstrual flow. Sometimes, or I would say in most women, this menstrual flow not only comes outside and it can be seen from outside, but also flows back, so as to speak, through the tubes and collects in the pelvis. This is not a problem. The problem is, in some women, this blood creates a reaction sort of a thing. And in this woman, the blood that collects in the pelvis leads to a condition which is known as endometriosis, whereby there is some sort of an immune response to the blood that's collected in the pelvis. The body doesn't like the blood that collects, and the body reacts in an abnormal way. What it does is, there is collection of this endometrial tissue or menstrual blood in different parts of the pelvis, sometimes also far away. And this menstrual blood or endometrial tissue somehow becomes reactivated in its new place. It starts periodic building up and shedding off as it would inside the womb. So then you have two active areas of endometrium. One inside the womb, where it is being built up and shed off every month during menses, and one outside the womb, sometimes in the pelvis, sometimes on the surface of the uterus, sometimes on the surface of the ovaries, and rarely as far as in the lungs or in the nose. So there is a problem that happens in some women. What is the problem? Why does it happen? We don't really know. All that we know is the menstrual blood, which is supposed to get out of the body, somehow in most women gets collected in the tummy and gets absorbed by the body. In some of these women, this blood does get collected but is not killed or absorbed by the body. Instead, this blood stays there and becomes activated endometrial tissue, just like as the parent tissue inside the womb. And this activated endometrial tissue outside of the womb or outside of the endometrium is what is known as endometriosis. So if you have really understood how this happens, although we don't know how it happens, then we also understand that this endometriosis could affect your womb or your tubes or your ovaries or the pelvis. Accordingly, we have different kinds of endometriosis these days. If it is affecting only the womb, we call it adenomyosis or endometriosis of the womb. If it is affecting the ovaries We have cyst formation, which are known as chocolate cysts. So we know this as ovarian endometrioma. It sometimes affects the tubes, damages them and swells them up, and that leads to hematosalpinx and tubal blockage. And very, very rarely it might affect the peritoneum and the pelvis. How does this lead to infertility? Now, if you remember, what happens in a natural cycle is that the follicle grows in the ovary, is released and is picked up by the tube. In endometriosis, this becomes a little bit of a problem because the ovary is surrounded by menstrual blood or endometrial tissue which is not supposed to be there. Many times the ovarian function is compromised and it cannot really grow the follicle. Even if it grows the follicle, rarely the follicle may not release the egg because of the surrounding blood. If it is released by the egg, it is falling into the pelvis where there might be old menstrual blood lying around, which may be very dangerous and toxic to the egg, and the egg might get damaged or macrophages might eat it up before the tubes can pick it up. The menstrual blood that's all collected around might not allow the tube to be able to pick up the egg properly. Sometimes what also happens is the tubes themselves may be swollen and full of this menstrual blood. Then there is no chance for the egg to be picked up. Rarely, even if the tube is able to pick up the egg, because of the past swelling up of the tubes and the bulky uterus, the sperms may not be able to travel all the way till the egg. And finally, even if the embryo forms, because the blood collection in the womb is bulky, the blood supply to the womb lining may not be good, and therefore there is a much higher chance of miscarriage. So in all, it's a pretty sad story if you are suffering from severe endometriosis. Okay, so if endometriosis affects so many things, then is it that nobody with endometriosis can ever get pregnant? Luckily, no. You know, nature is so much smarter than all of us. So many women have endometriosis, but very few of them actually require our help. And thank God for that. We have to understand that endometriosis is an immune response. The body responds erratically to the menstrual blood that has somehow found its way in the pelvis. The immune response may change with time. The immune response may get aggravated with some changes that we don't know, we don't understand much about. At the same time, we have to understand that in spite of all this immune responses happening, the body largely still wants to get us a pregnancy. So all said and done, even if I see somebody with the severest of endometriosis affecting the uterus, the womb, the ovaries, the tubes, I might still be pleasantly surprised when she comes back and tells us that she is conceived on her own. So first thing to remember is, even with endometriosis, almost 85-86% women would definitely get pregnant on their own. So in most cases, we don't have to do anything. You would possibly get pregnant on your own. It is just that there is a difference between the normal population and endometriosis population, in the sense that the frequency of getting pregnant may be a little low. In normal population, the egg gets picked up, gets fertilized, and an embryo forms maybe once in 3 or 4 cycles. Whereas in endometriosis, because of a problem at every level, this may happen once in 8 or 9 cycles. But this definitely happens in most women on its own. So just be patient. As far as ART or assisted reproductive techniques are concerned, we have now evolved a sort of a consensus on how to tackle women suffering with endometriosis. Before we discuss how to help these women with endometriosis achieve a pregnancy, we first understand how we diagnose endometriosis. Classically, the diagnosis of endometriosis is through laparoscopy, where we put a scope through the umbilicus of the woman, check for these deposits in the pelvis, and then confirm that she has endometriosis. But nowadays, because we have the access to ultrasound machines, we do not always depend on the laparoscopic diagnosis to establish endometriosis. Sometimes we suspect endometriosis on ultrasound findings and go ahead. So what do we do? Typically, a woman suffering from endometriosis would always complain of painful menstrual cycles, pain during sex, and difficulty in passing motions during menses or before and after menses. These are classical symptoms. They may or may not be present, but they are mostly present in our women. When we do an ultrasound for these women, we tend to see that the ovaries and the uterus are adhered to each other, meaning at least one of the ovaries is sticking to the back of the uterus. Sometimes we are able to pick up a cyst in one of the ovaries which has low echoes, which suggests that there is blood collection around. Sometimes we see some blood collection in the pelvis, which alerts us to the fact that it could be endometriosis. But largely it is a diagnosis based on the symptoms given to us by our women. Very often when we check, their prolactin levels are high, their ESR levels are high. And yes, when we do a laparoscopy, we are very sensitive to try and detect little deposits of these blood cells or endometriosis cells in the pelvis. So this is how we establish endometriosis in most of our women. The reason why I need to establish endometriosis is because then we can go for an algorithm of treatment which has been derived by a lot of doctors going through a lot of these patients and their treatment procedures. So now we have sort of a consensus, which is what I am going to share with you now. See, as we've understood, in endometriosis there could be grades. There could be very minimal or mild endometriosis where little amount of blood is collected or deposited on the surface of the uterus or in the ovaries, but largely the pelvis is alright. Or there could be the other extreme where blood is collected and frozen everything like an ice cream. There is nothing that can be seen separately. The ovary, the uterus, the tubes are all stuck to each other and nothing can be moved. So you could have all kinds of situations in between. A very mild kind of an endometriosis or a very severe kind of endometriosis. First thing that we need to understand is the severest of endometriosis can conceive naturally, and the mildest of endometriosis may find it very difficult to get pregnant even with an IVF. Once this is clear to us, let us now understand the protocol of managing women with endometriosis also requiring help for pregnancies. See, when I do an ultrasound or when the patient comes classically with the symptoms that we discussed and we suspect that she might have endometriosis, the first thing that we should do is check for her AMH levels. The AMH blood test will give me a stat information about her ovarian condition as to the number of follicles she has in her ovaries. This will help me decide as to how fast or how quickly do we need to get her pregnant. What does this mean? If the AMH levels are low for somebody, then she is essentially having very few eggs. In her case, we need to do a IVF or a fast track treatment to get her pregnant as soon as possible, because she may not have eggs left for any long-term therapy. Whereas if somebody has a lot of eggs, her AMH level is good, in that moment we can try to get her pregnant naturally as well if we can restore the anatomy or the normal shape and situation of the pelvis. So this is the first and the foremost guiding principle. We check the AMH levels, and based on the AMH levels then we decide as to how fast or how quickly do we need to get her pregnant. The next step I would recommend is always to go for a laparoscopy. The laparoscopy will help us detect endometriosis and burn up the deposits if they can be seen and clear up the deposits. Sometimes with laparoscopy, you can free up the ovary and the uterus, you can make the ovary come back to its normal position, you can check the status of the tubes, if there is scarring in the tubes, if there is bad collection in the pelvis and the uterus is all coiled up, stuck somewhere, then we know that she has a very little chance of getting pregnant naturally. On the other hand, if there is some adhesions, some collection, but that can be cleaned up, then at least for the next few cycles she has a decent chance of trying to get pregnant on her own. So once the laparoscopy is carried out and we think that the tubo-ovarian relationship, meaning the tube and the ovaries can come close to each other and the egg can be picked up by the tube, is decent enough, then we try and get her pregnant through what is known as ovarian stimulation and intrauterine insemination. In ovarian stimulation and intrauterine insemination, we give her medications, tablets and injections, tablets or injections, make her produce more than one egg, so the theoretical chance of the egg getting picked up by the tube is higher, and when the eggs are ready, instead of having a sexual contact, deposit the semen in the womb. A lot of studies have shown that this gives her a higher chance of getting a pregnancy as opposed to a natural contact method. If this has been tried for a couple of cycles and there is no pregnancy, then we recommend that she should go for an IVF treatment. On the other hand, if the laparoscopy suggests that things are badly scarred, they're all stuck badly and they cannot be freed up, then there's no point wasting time trying naturally, and we should move for an IVF immediately. We also need to understand that the first laparoscopy is the best laparoscopy. If somebody has undergone a laparoscopy treatment some time back and she still hasn't gotten pregnant, chances are a second laparoscopy still will not work for her. So for such kind of women, it's better to go for an IVF rather than suggest a second laparoscopy. Ovarian cystectomy, that is removing the blood that's collected in the ovary, is usually not recommended by us, because while removing this blood, we also take away some part of the healthy ovarian tissue that reduces her ovarian reserve. Rather, what we say is to open up the cyst and drain the liquid that's collected rather than removing the cyst, because that might still help us preserve some of the healthy ovarian tissue. Once we have done the laparoscopy, we have tried naturally through intrauterine inseminations and ovarian stimulation for 3-4 cycles. It hasn't worked, then IVF is the way. Also, if her AMH levels are low and she has failed a laparoscopic surgery previously, in these 2 cases also, IVF would be the next step for us to consider. So IVF for endometriosis again is a very complex thing. As we've understood, your ovaries might have cysts, your tubes might be swollen up, or your womb might be all big and bulky because of the blood collection. We need to take all these 3 aspects into consideration while doing an IVF. If the tubes are swollen up with dirty fluid inside, with menstrual blood inside, there's a high chance that that fluid might regurgitate back into the womb and not allow for the IVF to succeed also. Then we need to go for a laparoscopy and remove the tubes so that this dirty fluid cannot come back to the womb. This is known as surgery for hydrosalpinges before going for an IVF. There's a lot of data, a lot of information that this actually increases the pregnancy rates. If the womb is bulky, then there's a chance that the blood supply to the womb is not reaching properly and she might have miscarriages or poor implantation, in which case we need to reduce the size of the womb. Unfortunately, there is no good surgery for this. We need to stop her menses for some time, insert something called the Mirena, which is an intrauterine device, or give her an injection, a GnRH analog, which will stop her menses for 3, 4, 5 months, and that will help us shrink the uterus. Both of these are temporary measures, and they should be done once we have been able to take out the eggs, because this might take longer and this might reduce her ovarian reserve further. So my classical protocol as far as IVF for endometriosis is concerned is to start her IVF as soon as possible, giving her injections to produce as many eggs as possible, collect them and form embryos. Once you have formed embryos, then go for the tubal surgery in case the tubes are swollen, or give her injection, GnRH analog, or put a Mirena inside to help her shrink the uterus if the uterus is bulky. All this might take as little as 3 months and as long as a year. We have to allow that time. Once the uterus is shrunk, maybe not to the normal size, but maybe a little near normal size, that's when we thaw, that is, warm up the embryos that have already been vitrified or frozen, and then use those embryos to be put back to the womb. So although it may sound a lot of time, but this actually gives you a very good chance of taking back a pregnancy or a baby home. So as we understand today, endometriosis is tricky, but in this times that we are in, medical science definitely has a solution for most of these women suffering from endometriosis. As we understand, endometriosis is tricky. There is no known cure for endometriosis. All that we can do is maybe stop the menses and shrink the uterus, remove the tubes and therefore take care of the hydrosalpinges, drain the cysts, or maybe give her medicines to stop her menses so that the cysts can disappear, burn up the endometriotic deposits in the pelvis, but not stop or halt the process of endometriosis till the time her menses are continuing. In spite of all this depressing news, the good news is that in these times, with lot of medical treatment available, most of these women, even with the severest of endometriosis, if they have healthy oocytes and a decent enough uterus, can be managed to get pregnant on their own. Very rarely, if the endometriosis has been there for a long time and there has been a profound damage to the egg quality, we might need egg donation. But even with egg donation, it has been found out through a lot of studies that the womb's ability to hold embryos and give birth is just as equal, just as the same as other women. So there is not much need to despair. Help and hope is there for most of these women as well.